Greetings. This is Graham Warren working with you on the hip op case. It's a thrill to be here and to be also to have worked with my co-authors on this case, Julie Katie Ray and Paul Kanuja, Dr. Paul Kanuja. So this is an arthroplasty case where we're looking at hip and knee replacements at Hipkins Hospital. The actual configuration of the ORs and the assignments and times and so forth are part research-based and part fiction. So I'd like to, in this initial clip, explain the current setup, and this model is trying to try and give us an assessment of what the performance is in that in the current setup. In subsequent clips, I'm going to look at possible innovation, meaning process change, through the lens of our four takeaways. They are, what do the utilizations look like, and does it make sense to increase or decrease capacity to change those utilizations? The second is to see, what the possibilities for additional pooling may be, and to see what the impact of those changes would be. The third is variance reduction. There are variances in most of these activities, and you could squeeze some of that out by training, by standardization, and so forth, possible automation. And then the fourth one is, psychology matters. And so the question is, could you reduce patients and their families' perceived weight using any techniques? It's a matter of high stress and worry, anxiety for most folks undergoing the surgery and their families, and if there's a way to minimize the length of time that they're in that state of worry, so much the better. Okay, so the high level view of this model is that there is a stream of patients coming in. It's a pooled arrival stream, and then they get split into either OR stream A or OR stream B. This is not how it happens in reality. Basically, there's a surgeon associated with the two ORs in this upper stream, OR stream A, and one surgeon associated with OR stream B. And in real life, of course, you know who you're going to get your surgery done by, and you've done all the consent, relative to that surgeon. But in our case model, we are going to say that you show up and you join the line, the OR line that is the emptiest, meaning the one that you're going to get your surgery done quickest in. So the one with the shortest line. Okay, so that's a little bit of a fiction, but some of the content here, Dr. Kanuja has been gracious and assisting us with research-based mean processing time, standard deviations, and whatnot. Okay, so the patients arrive in the current model with a normally distributed inter-arrival time, and that is shown here. Inter-arrival time is normal, and it has a mean of 90 minutes with a standard deviation of 10. And we get two arrivals at a time. And then they come in here and they get split. And then wherever the shortest line is, that's where these folks go. So this OR, all four ORs, there's two in OR stream A and two in OR stream B. They operate from 7:30 in the morning until 5 p.m. And this is typical of the real operation of a hospital system with this kind of surgery. Most of the folks go home at the end of the day after the surgery, somewhere from, depending on the nature of the underlying conditions and pre-existing conditions, 50 about 30 to 50% end up staying overnight after their surgery in the hospital. But most folks could do go home. Okay, so what happens is when you arrive, first thing I should just note is we're interested in the flow time that is going to start from the moment that you arrive until the end of the cleaning of the OR in which you had your surgery done. And that's just a KPI that is of interest to hospital administrators and the director of surgery. So we're going to start a clock. You get registered. And you get registered by one of the registrars. There's a registrar pool here, and there are two registrars, and they serve both OR streams, meaning all four OR. So any patient that comes in either stream A or stream B, is registered by one of these two registrars. So you line up, you wait for your registrar, all the paperwork and whatever else is needed is done, and then the registrar is released, and that person then can go and serve either somebody else that's waiting in this A stream or in B stream. And there's two registrars. So the registrars are already pooled. And then you go through a process, a pre-op process where, you're evaluated for anesthesia and, you receive your anesthesia. A lot of these are spinal anesthesia cases. And there is one anesthesiologist here. So there's this pool called anesthesiologist pool A. So there's just one there. And you now this is done outside of the OR. And then we grab an OR. So an OR is a resource. And there are two ORs. You can see in the operating room pool A, there are two ORs. So we grab an OR and we assume that it's clean. And then we grab the surgeon, and there's just one surgeon here. So let's just have a look at the times on these things. The registration is normally distributed in duration with a mean of 5 minutes and a standard deviation of 2 minutes. So recall the analogic protocol or format for the delay time. It's normal of sigma comma mu. So this mu and sigma are kind of reversed from what we're normally accustomed to. So the 2 is the standard deviation, 5 is the mean. Anesthesia takes a mean of 25 minutes with a standard deviation of 7.07 minutes. The OR doesn't take any time to grab. Once it's available, it's just grabbed. And then the surgery is based on research. There's an article by Dr. Kanoja and his co-authors, and that is presented in the case. And the duration of the surgery is most affected by the patient's BMI. Low BMIs get done a little faster. Large BMIs take long, and the outcomes for such patients is not as good as others. So what we've done is we've taken a weighted average of the times, and we've taken a weighted average of the variances to get the mean and the standard deviation of the surgery time. So it's a mean of 100.71 minutes and a standard deviation of 8.09. So then you're done with the surgery and you head off to recovery. And we're not modeling that process. That recovery is typically around 2 hours, of course, with variation. And then from there, you're either discharged or you get sent into the hospital to overnight. But from the perspective of the process of interest, we're going to then rely on the EVS pool, which is a pool that serves both OR streams. There's currently 3 people here. And that OR is cleaned, and then the instrumentation is replaced, and that rest of the process is completed. And then we, once that OR is clean, then we stop the clock, and we're interested in the time of arrival to the end of cleaning of your OR, because you sort of dirtied it in some sense in your surgery, and so once that OR is clean, then that is the end of the flow time of interest here. Then we release the OR so that it can be available. It's clean, can be used for the next patient. And then we just, that patient is just taken to the sink. And the setup for OR stream B is the same. Now, as far as statistics and information, data gathering from this simulation, we've got a flow time distribution. I did mention that this OR runs from 7:30 in the morning until 5 p.m. at night or in the evening. And we only generate 6 arrivals and with this inter-arrival time. So that we can only simulate up to 570 minutes. Now, this is a situation, a system that's not really going to run at steady state, meaning it's not going to be sort of operating normally at sort of normal capacity for very long, because there's a warm-up period as patients come in the morning, and then toward the end of the day, you're sort of flushing out the last folks, and you're not registering any new people after, let's say, 3 o'clock. So what is going to be of interest here is, how many can we get done? And do the changes that we make in, for example, variances or pooling and other decisions, does that help us achieve a higher count of patients that complete the process and or reduce our average flow time? The average flow time is going to be, it's a KPI that's been set by the director of surgery. And minimizing it is to the advantage of patients, because other than the cleaning time, this is really the time that they're sort of being worked on, so to speak, pre-recovery. And so we can minimize that. That's a reduction in the time, the anxiety time of the family, and it's the reduction in the time that you're actively being worked on. So it's to the advantage of both patients and family to get that flow time down. So these are our primary KPIs. So the statistics that we're going to be reviewing are the following. We're going to look at utilizations of all of these pools: the registrar, surgeon pool A, surgeon pool B, the anesthesiologist in both A and B pools. The cleaning pool, this is really the EVS pool, and then also the operating rooms, pool A and pool B. Okay, so these are the environmental services. We're also going to get the flow time histograms, and we'll get a mean there as well. Right, so we've basically got our model. We're going to run it in the next clip and talk about performance. We're just going to do one run, and then in the third clip and beyond, we will start to think about, how could we make changes here potentially, and start to assess the impact of those changes.